Hello, everyone. We are Group 4, and today we'll be talking about trauma-informed care in pregnancy. So, in this presentation, we'll be covering 5 main topics. Number 1 is who needs to know. We'll be identifying the target population for trauma-informed care, and also who can make change. Number 2 is what do they need to know, defining trauma-informed care and related factors. Number 3 is why is it so important? We'll be exploring how trauma impacts the care of the childbearing family. And number 4, what can nurses do? We're defining the role of nursing and also exploring possible interventions. And lastly, number 5, we'll be opening the floor to questions for us and also presenting some questions for the audience to think about after the presentation.
To start off, we're going to be looking at who needs to know about trauma-informed care. Firstly, OBGYNs and nurses, as well as other healthcare professionals that come into direct contact with pregnant or postpartum women, should be well equipped to provide trauma-informed care. They should be able to observe for signs and symptoms of past or present trauma, such as agitation, anxiety, sudden outbursts, or difficulty trusting. Additionally, screening for trauma should be incorporated into the plan of care. To allow for effective trauma-informed care, healthcare providers should work to build rapport with the client and foster a safe environment for clients to open up. Secondly, as part of trauma-informed care, pregnant or postpartum clients with a history of trauma or those who are currently experiencing trauma should be made aware of the resources available to them. There are numerous resources such as support groups or individualized therapy that may ease the feelings of emotional stress, loneliness, or helplessness that often accompany trauma by creating a nurturing and an understanding environment for them. Additionally, women experiencing trauma can contact various national hotlines that are available to report instances of violence. Next, we are going to focus on what exactly we need to know about trauma-informed care. Before looking into the specifics of trauma-informed care, we want to establish a basic understanding of what trauma is. Traumatic events can span a lifetime and include a range of events such as adverse childhood experiences, sexual assault, intimate partner violence, and violence based on sexual orientation. Moreover, past traumatic birth experiences, such as unexpected complications or outcomes, can also have significant implication on one's perception of their pregnancy as well as on their health outcomes. Additionally, obstetric trauma or violence, in which the pregnant or postpartum client may have suffered abuse or disrespect at the hands of healthcare professionals, can result in a distrust of the healthcare system, which inadvertently results in negative health outcomes. Trauma has significant effects on pregnancy outcomes, including increased pregnancy complications such as miscarriages, placental abruption, and preterm birth. These increased pregnancy complications can be a result of a person's response to trauma. For example, trauma survivors are at significant risk for engaging in dangerous coping mechanisms such as substance abuse and self-harm, which can have profound negative effects on both the pregnant mother and her child. Survivors of trauma may also face various mental health disorders such as anxiety or depression, which can further exacerbate these unhealthy behaviors. Various research has also shown a positive correlation between trauma and chronic disease. For example, post-traumatic stress has been linked to lower HDL levels and higher triglycerides, greater systolic and diastolic BP, greater BMI, all of which increase the risk for cardiovascular disease. Previously discussed coping mechanisms such as smoking, substance abuse, and alcoholism can also increase the risk of lung and liver disease. So, what is trauma-informed care? Essentially, the trauma-informed model of care is a framework of practices and principles that acknowledges the different ways in which previous trauma influences a person's life experiences. In the context of pregnancy and childbirth, trauma-informed care focuses specifically on how past or present trauma can affect the pregnant mother's outlook on her pregnancy, as well as her transition into motherhood. This model of care is implemented primarily through screening for trauma. However, effective screening for trauma is impossible without establishing a trusting relationship between the nurse or physician and the client in which the client feels secure enough to share about her experiences.
So, why is trauma-informed care so important? There are many risk factors involved before, during, and after the pregnancy. The prevalence of intimate partner violence, or IPV, during pregnancy may vary, but it's estimated that 300,000 pregnant women in the United States alone are affected by IPV annually. The risk factors for IPV associated with pregnancy can occur spanning from 1 year before conception to 1 year following the birth of a child. A history of IPV can also increase risks in physical trauma caused by the pregnancy and the birth themselves. These impact both the mother's and the baby's health and also mortality rate. It's also important to consider stress during labor. Victims of IPV or patients with other history of trauma are more prone to stress and the inability to effectively cope with it. Hormones and neurotransmitters released in response to stress, or catecholamines, can cause dysfunctional labor. So this can mean reduced uterine contractility, inhibited cervical dilation, and also more perceived pain during labor. This produces an increased amount of time in labor, but also a decreased amount of comfort. Continuing to explore the importance of this type of education, we recommend reading this study entitled Pregnancy and Childbirth After Sexual Trauma: Patient Perspectives and Care Preferences. So this study highlights some statistics such as 1 in 5 US women will experience sexual violence in their lifetime, and of course this will affect future pregnancy and childbirth experiences. And also it explores how to improve obstetric care for trauma-affected individuals, because really there is a current lack of evidence-based practice for this area of care. Aiming to bridge that gap, they suggested interventions such as using sensitive language that doesn't trigger memories of past experiences and avoiding trauma cues or trigger words, maintaining therapeutic communication, and considering patient preferences. So this means asking patients about their comfort level regarding body exposure, the people present during examinations or labor or other procedures, and also the participation of male healthcare providers in their care. We also include explaining reasoning for and method of certain procedures to make sure the patient will be ready for them. So this study really aimed to translate these statistics and experiences into the population's needs and preferences into specific suggestions for improving care for the childbearing family. So we recommend this source because it was published in the Obstetric Anesthesia Digest in 2019, which means it is peer-reviewed and recent. It was also held at Boston, Massachusetts. So being in the same country, we can kind of assume a similar demographic and cultural consideration makes it relevant to our population. And also, it's a qualitative study with participants required to have previous birth experience and different backgrounds. So it highlights individual experiences with the focus of nursing being to consider the unique patient and their needs.
Nurses have the most interactions with patients. They can form a trusting bond with these women and recognize signs of intimate partner violence such as frequent absences from prenatal visits, frequent bruising or injuries throughout the body, frequent accidents, overly involved or indifferent partners, and nonverbal cues about the relationship between the woman and her partner. Nurses in women's healthcare settings and emergency departments are most likely to see rape survivors and abuse survivors first in the healthcare setting. They document history and provide immediate physical and emotional care. They can also screen for interpersonal violence. The target population is mothers with a history of or risk for trauma, whether it's physical, emotional, or sexual. Barriers to health include the inability to maintain physical and psychological health, the lack of therapeutic communication between the patient and the provider. Past trauma also discourages many patients from seeking care during pregnancy, and a lack of trust in healthcare providers if trauma happened under their care. Poverty, financial burdens. Some pregnant women lack the income to attain prenatal care, or they're financially dependent on their abuser. Physical violence is also a detriment to the mother and baby's health. Some health promotion interventions include educating the healthcare team on sensitivity training and preventing re-traumatizing patients during labor or other treatments. The nurse can refer the patient to a social worker and resources that address her financial problems, connect her to organizations and clinics that offer free prenatal care and resources, screen for intimate partner violence, and screen appropriate fetal development and assess the mother's health consistently throughout the pregnancy. Once again, the nurse can recognize the signs of intimate partner violence and build trust and ensure confidentiality with therapeutic communication. And some questions for the audience to further the discussion is, how can pregnancy and motherhood change a woman's motivation to seek assistance? How can nursing students become more prepared for trauma-informed care? And what causes victims of intimate partner violence to refrain from seeking aid?
So we're opening the floor to any questions you might have for us as well, but here are the references we used for this presentation, and thank you all for listening.